renal, most of the time is two conditions. One is a cancer, other one is a kidney stone. These are the two things that blocking after the kidney. So we are not worried. If you see in this book, the most problematic to understand is this guy. These two is the difficult one. Differentiating pre-renal and intrarenal is the most difficult. And also look at the post-renal. They keep putting varies, because, we will see that. So our first goal is to differentiate pre-renal from intrarenal. Is everybody clear, folks? Okay. Now, normal physiology. Okay. First, normal physiology. You have a bun in the blood. That's your blood urea nitrogen, right? So that's be a bun and creatinine. So how does it work? Bun, you come in, you filter. Some of them get reabsorbed, some of them get excreted. That's your bun. Everybody clear, folks? That's a normal physiology. When it comes to creatinine, everything excreted. In fact, they are secreted too, isn't it, folks? So they are secreted. That's your normal bun creatinine. So you must know how normal bun creatinine works. Is everybody clear, folks?
You need to go one more time.
So the bun enter the kidney. Some of them are reabsorbed. Some of them are excreted. Creatinine filtered in the kidney. Pretty much all of them excreted. That's normal. Imagine if you have a renal artery stenosis. I'm just making up an example. If you have a renal artery stenosis, bilateral renal artery stenosis, can this bun and creatinine enter kidney properly? No. So they're going to back up in the blood, isn't it, folks? So anytime you see increase in bun and creatinine, it tells you it's a pre-renal problem. You see that? Anytime you see increased bun and creatinine, it's always a pre-renal problem. Now, what causes pre-renal problem? I will make it simple. Anything that causes hypoperfusion to the kidney. Anything that causes hypoperfusion, whatever they have given in this book, they all causes hypoperfusion to the kidney. You have hypovolemia, that means low blood in the body, that means low blood to the kidney. Decreased cardiac output, that means less blood to the kidney. Is everybody clear, folks? You could write bilateral renal artery stenosis as another example. Are you guys clear with this, folks? Anybody has issues here? No, because this is the last part that concludes everything what we studied. So that's an example for pre-renal renal failure. Another name is pre-renal azotemia. So you have increased bun and creatinine. Is everybody clear, folks? Because they are not even able to get into the kidney, so they are backing up in the blood. Are we good? Okay. Now, I want you guys to imagine intrarenal. I'm going to make up an example, your tubules. So even though I'm showing the PCT, I want you to think all the tubules. Okay, I can't draw the whole tubules, but I want you guys to assume all the tubule cells are dead. Something happened, your tubule cells are not working. Okay, so the tubules are dead. It could be acute tubular necrosis. It could be anything that affects the kidney. Now I want you guys to tell me, when the bun is coming in, we said some of them get reabsorbed, some of them get excreted, isn't it, folks? Can you reabsorb that some of them? You cannot, because the tubule is not working, isn't it, folks? So what does that tell you? The entire bun is getting in the urine. Is everybody clear, folks? All the bun is getting in the, and then on the other hand, of course, your creatinine will go excrete, has no problem. So what does that tell you? Anytime you see a bun creatinine is decreased, that's always intrarenal problem. See, looking at the bun creatinine itself can tell you whether it's a pre-renal or intrarenal. Is everybody clear, folks? That itself can tell you it's intrarenal or pre-renal. Are we clear, folks? Increased bun, pre-renal. Decreased bun, intrarenal. That's what I'm showing it in the book. All good, folks? All right. Now, next, let's say you didn't pick on that. We have another way to pick. Let's talk about urine osmolarity. So let's say the first problem, pre-renal. What did we say pre-renal mean? Hypoperfusion. Hypoperfusion is the problem, isn't it, folks? Watch me and write, because this is a little tricky if you miss it. If we have hypoperfusion, what will happen to renin? Renin goes up. If renin goes up, aldosterone goes up. If aldosterone goes up, you will start reabsorbing sodium with water. And of course, that's done by aldo. You should also have ADH that will even further reabsorb water. Is everybody clear, folks? Okay, it further reabsorb water. That means every single water, let me clean this up a little bit. Now the tubules are working because we are talking about intrarenal, isn't it, folks? All the water in this area with sodium is getting reabsorbed. All the waters are getting reabsorbed. Agree, folks? If the water is reabsorbed, what happened to the concentration of the urine here? Up or down? The urine should be well concentrated because we took all the water away from there. Does that make sense, folks? Because we reabsorbed all the water, so the urine is so concentrated. So the urine osmolarity is very high, more than 500. Urine osmolarity is very high, is because they are reabsorbing all the water with the help. Is everybody clear, folks? You see, it's all starting with hypovolemia, hypoperfusion, how renin system. You have to know so much of physiology to understand that. Anybody didn't understand this? Which part?
So, okay, first I understood when you said that if there's a stenosis, then the bun and creatine would be increased, right?
Yeah.
So I'm confused why, if there's a stenosis, wouldn't the osmolarity would be less?
No. The osmolarity, renal artery stenosis, the problem is happening in the renal artery here. If the renal artery has a stenosis, the blood that entering is less. You agree with that? If the blood is less, do you agree that renin will be stimulated? The renin will stimulate aldosterone. Do you agree? What does aldosterone do? Reabsorb sodium and water, isn't it? So even though less blood and water coming in, we will reabsorb all those water back in there. Now, renal artery stenosis is not 100% block. If it is 100% block, the kidney is dead. So there are some blood coming in, that blood has water. So your ADH and aldo will reabsorb water and sodium. Do you agree? So when you take the water out, the urine will be more concentrated here.
Okay, so I mean, there's nothing wrong. You know how you said it in the intrinsic one? There's something wrong. The bun is not being reabsorbed.
No, here, see, I'm showing it in this picture. These cells are working properly.
Okay,
that's
so
why
there's nothing wrong in the, okay.
No. So that's why the osmolarity is high, more than 350. So we call it 500. So it's a concentrated urine. Is everybody clear, folks? Now look at the next example. Okay, so listen carefully here because I'm using the same diagram, so don't get confused. Now I have a problem with intrarenal. Intrarenal mean these cells are dead. All these cells are dead, okay? Now I am bringing in more blood filtered because I have no problem bringing in, I have no problem filtering. But can I reabsorb any water? You cannot because the tubules are not functioning. So all the water is going in the urine, making the urine very diluted. Is that clear, folks? So your urine osmolarity should be decreased here. You could see the urine osmolarity is less than 350. 350 is the borderline for urine, not the blood. Urine has a different amount, blood has a different. So here you could also write it down here if you want. This is a concentrated urine. This is a diluted urine, folks. Are we clear so far? Anybody still lost?
The macula densa doesn't have any problem still reading blood flow, correct? Or no?
No, because you're talking about intrarenal?
Intrinsic, yeah. Mm-hmm.
Intrinsic have no problem reading. Macula densa are still working on it.
So they can still activate Renin, okay.
Yeah.
It's just you can't reabsorb.
No. Okay. That's that. Now, even remember, even if macula densa don't work, sympathetic is still watching, right? So now, third one. So let's say you couldn't pick with bun creatinine, and then you went for osmolarity. Let's say you forgot about osmolarity, you couldn't pick with that either. So what else we can do? Let's go back for one more thing. I'm going to redo it, this section. So now I'm going back to pre-renal. The minute you have a pre-renal problem, you should already know we have to reabsorb sodium. Do you guys agree, folks? So all the sodium will be reabsorbed. Agree? If you reabsorb all the sodium, would you excrete a lot of sodium in the urine? No. So the urine sodium should be low. Is everybody clear, folks? Now look at this. Urine sodium is less in pre-renal. Urine sodium is less in pre-renal. Is everybody clear, folks? Now let's go back. I have an intrarenal problem where the tubules don't work. I have no problem bringing in fluid, but now you told me, would you reabsorb any sodium here? You cannot. So all the sodium will be high in the urine, isn't it, folks? Look at that. High in the sodium. All good? So you looked at serum bun creatinine, then osmolarity, then urine sodium, okay? The urine sodium. Now the last one here is called fractional excretion of sodium, okay? Now to make it simple, fractional excretion of sodium goes exactly with the urine sodium, because urine sodium per minute fractional is per fraction. It's in the same direction. If you have decreased urine sodium, your fractional sodium is also decreased. If you have increased, your fraction is also increased. Think about cardiac output and ejection fraction. They go in the same direction. Is that clear, folks?
Can you re-explain the fractional one again, please?
Fractional excretion of sodium means you excrete sodium per fraction. That's it. So anytime you increase the total sodium, the fraction will also increase. Anytime you decrease the total, the fraction will also decrease. They both go in the same direction. Clear, folks? So you have 1, 2, 3, 4 different units or 4 different methods. You could tell whether the patient has pre-renal or intrarenal. Is everybody clear, folks? You could look at the bun creatinine. If you can't make a decision, you go to urine osmolarity. If you can't make it, go to urine sodium. If you can't make it, go to fractional excretion of sodium. If you still can't make it, move the question and move to the next one. That means you won't get that question right. Okay. You have 4 information to pick it. If you don't pick it, move to the next one. Don't flag it. There's no reason to come back to that question. Okay. So that's this. Any question in this section, folks?
Why again was the sodium urine high in the intrinsic?
Because your tubule, remember in intrinsic, your tubules are not functioning, so no reabsorption or secretions. So when you have sodium coming in here, we cannot reabsorb, so we are excreting in the urine. Okay, so that's the idea. The first thing for you to understand, intrarenal problem means your glomerulus or interstitium, nothing is working, folks. It's just getting excreted. You see, it's either that, glomerulus, or this one, folks. Everybody clear? So you could tell the difference between pre-renal and intrarenal? Anybody has any questions? All clear? Okay. Now the post-renal, we don't, because if you see, the problem for post-renal, it's after the kidney, usually in the male BPH or kidney tumor, what is it, a bladder tumor, something that's right. So that's why, look at this, there's only few, we leave it alone because the problem is after the kidney, it takes so long for this to cause this. By the time they cause that, they should be, they shouldn't be alive. That's what the theory is. Okay, it takes so much time, folks. That's the idea, folks. Okay, so that's acute kidney injuries. Is everybody clear, folks? So you have pre-renal and post-renal. Do not, in my opinion, I only use these two. One, creatinine and osmolarity is easy. Okay, but you could use any of the four. But that's what I use it quickly to identify pre-renal or post-renal. Everybody clear, folks? All right. So that take care of acute kidney injury. Oops. If you know that, then we're gonna go for, where is that page? I just went to here. Consequence of renal failure. Now, once a patient has a renal failure, they will develop all these consequences, folks, okay? We should be able to explain each of these consequences, okay? Now, if you see, they have metabolic acidosis, it's because they are not able to excrete hydrogen from the collecting duct. The tubules are not functioning. Clear, folks? Also, you could say in PCT, they are not absorbing bicarbonate. Agree? All right. Second, they have dyslipidemia. The reason increased triglyceride because they're excreting proteins in the kidney, folks, those binding protein, okay, co-binding protein. If you know why metabolic acidosis, you should also know why high potassium, because hydrogen and potassium excreted together in the collecting duct. If you can't excrete that, you cannot excrete. If you have a renal failure, you cannot excrete urea. So urea acts in the blood and uremia. This uremia can give uremic pericarditis. Is everybody clear, folks? Okay. The next one, sodium water retention. We just talked about if you have a pre-renal failure, your body will try to retain as much as possible, right? That's retention. Kidney is important for growth, folks, okay? There could be a growth retardation and developmental delay. Because of the growth alpha-1 hydroxylase, you have to activate to get more calcium for the bone to grow, and all these things are involved, folks, okay? Last one, erythropoietin here. Where do we release erythropoietin from? Peritubular capillaries, okay? Peritubular capillaries. When your kidney fails, we studied in endocrine, most of your calcium function goes away. Does that make sense, folks? So if your kidney failed, what is the only way to maintain the blood calcium? Type it up. If your kidney fails, what is the only way you can maintain your blood calcium? Increase PTH, yes, but what is the only way to maintain? Where are you going to get the calcium from? From bone, because you only have bone calcium, right? So you destroy the bone. That's called renal osteodystrophy. That's not a new topic. We covered that in endocrine. Anytime you break down excessive bone to maintain the blood calcium, we call renal osteodystrophy. They explained it again for you on the next page. It's the same explanation. Is everybody clear, folks? These are all consequence. If you really want, I would try to add, let's see if they put it somewhere. Platelet dysfunction. Uremia inhibits platelet function. That's why people with kidney failure, they bleed. That's how they die most of the time. When people have a kidney failure, they bleed to death. So because they bleed. Because why? Uremia inhibit platelet function, folks, so they cannot do anything. Okay, so that's that. Incremental reduction in GFR define the stage of chronic kidney failure, folks. And then you have normal phosphate level are maintained during early stage, but then it increases. We already know. And we talked about uremia, folks. Okay, let's see. They talked about pericarditis, encephalopathy, but platelet. Make sure you know that. Is one of the, see, when patient has a kidney failure, the fear is anytime they can start bleeding from anywhere, folks. You will see bleeding from the ear, bleeding from the nose, any holes you have in the body, they will start bleeding, basically. Okay, so because the blood becomes too thin. So that's a consequence of renal failure. Is everybody clear? All right. So that concludes, and we have one topic that I have to go back. Renal tubular acidosis. 100% one question in this. You have to know this. It's going to be easy now. Since we finished everything, it's going to become super easy. Now, when it comes to renal tubular acidosis, first to learn, the renal tubular acidosis means no matter what's happening, you have metabolic acidosis. That's what it is. Metabolic acidosis. By the way, did you guys watch the video of acid base yesterday? Did it make sense? Did you guys try the method, the arrow up and arrow down? All right. Did it make sense or it did not? Was it just a movie? It seems like it. Okay, we'll do it again. Let's do that. Let me teach you acid base because it will make it easier for you to know acid base in and out for this. Okay, so how many people didn't watch it? Damn, half of the class didn't watch it. All right, let's do it. So after I finish acid base, everybody should watch it again that 1 hour. Okay, you will become so good at acid base after that. If not, you will never. But the reason behind I spend this much for acid base, when you see questions or even in real life, everybody comes first with acid base abnormality. That's how they come to you. That's where you start everything. Nobody's come and tell you I have Fanconi syndrome, treat me, doctor, right? No, you have to figure out everything. So acid base is very important, folks. This is your acid base. Now, when it comes to acid base, I always write carbon dioxide, bicarbonate. Carbon dioxide is your acidic molecule. Bicarbonate is your alkaline molecules. Okay. You don't have to write anything because when you watch my video, you could write again. It's better to learn now. Okay. So more carbon dioxide, more acidic, more bicarbonate, more alkaline. On the other side, I'm just going to put the pH axis. Normal pH is 7.35 to 7.45. As the pH increases, we call alkaline. As the pH decreases, it's called acidic. Is that clear, folks? Okay. Is your normal drinking water, the tap water, what I call, is it a normal pH? No. Okay. How do you know that? You know, I always tell, if you have a wound, let's say you have a cut, and you go to the hospital to get dressed, how do they wash that cut? Do they use the water or they use a saline? They use the saline to clean it, right? Why? But at home, what happened? When we cut, we just go in the tap and wash it off, isn't it, folks? When the tap water touches your wound, doesn't it kind of burns it quickly? Because the pH of your blood is different from the pH of the tap water. Especially for kids, we always use the saline to wash the wound because it doesn't burn because we are matching the same pH of the blood. Saline has the same pH as the wound. So the kid should not be crying when we clean their wound because we are using the saline. If they do, just smack them on the head. They shouldn't be. Okay. So that's that, folks. Okay. Now, that's here. When it comes to acid base, your body goes through 24 hours to maintain the normal acid base, but we will never be able to maintain normal. It always like an axis goes this way and that way, but your body will try to bring it to somewhere in the middle. So you will never have a perfect pH 24/7. Okay, that's the idea. Now the two organs that runs or maintain the pH, one we call lungs, we call it respiratory. The other one is called kidney. So we call it metabolic. Okay. Now, in respiratory, if you increase the accumulation of carbon dioxide, increase the accumulation of the carbon dioxide in the lungs. What did we say about carbon dioxide? Acidic. So more acidic you have, the more acidosis, right? The more carbon dioxide, more acidosis. So we call respiratory acidosis. That's your respiratory acidosis. The less carbon dioxide you have, the less the acidosis. So we call respiratory alkalosis. Everybody clear, folks? Now the next question comes, what causes this? What causes that? So what causes increased carbon dioxide? Anything that makes you breathe less, hypoventilation, will cause respiratory acidosis. Anything, folks, okay? Anything that makes you breathe less. Now, in this book, you have acid base here, right? I don't like this method, okay? This is too going around, but I would use this. You see, all those things that causes hypoventilation, acute lung disease, chronic lung disease, opioids is my favorite. Taking pain medication reduces the respiratory rate. That causes hypoventilation. My favorite to teach, not to take, okay? So that's all. I know what you guys are thinking. So that's respiratory acidosis. Carbon dioxide, anything that causes hypoventilation will cause respiratory acidosis. On the other hand, anything that causes hyperventilation, you are breathing fast. That means you are getting rid of carbon dioxide. You become respiratory alkalosis. That should be here. Hyperventilating, panic attack, anxiety, hypoxemia, all these things, folks. Okay, high altitude too. Now, remember, as you become respiratory alkalosis, you feel like you are throwing, you want to throw up. That's why people feel that when they are in the plane, because the flight is going on a high altitude. You are breathing faster without knowing yourself. So anytime you are in a respiratory alkalosis, it gives you motion sickness. Is that clear, folks? That's why we give the bag to breathe, isn't it, folks? What is the whole point of doing it? You are breathing the same carbon dioxide, so you are bringing that down. Is that clear, folks? All right. Now, that's respiratory. Are we clear here? On the other hand, in the kidney, anything that makes you to retain more bicarbonate. What did we say about bicarbonate? It's alkaline. So more bicarbonate, more alkalosis. So we call metabolic alkalosis. Anything that makes you to excrete bicarbonate, decrease bicarbonate. So that means you are losing bicarbonate or not forming. It causes metabolic acidosis. Is everybody clear, folks? That's the basic of acid base, okay? Now, when we have a metabolic problem or acid-base problem in the body, there's something called primary organ who makes the problem. So whenever our pH is changed to alkalosis or acidosis, whoever changes, it's called primary problematic person. It could be either respiratory or it could be either metabolic. We don't know who it is. So assume metabolic. Let's say for an example, metabolic is the primary problem. So the kidney is going through some hard time, then they are messing up the pH. Then your lungs will compensate for it. Is that clear, folks? So whoever the primary organ, the other one will help compensate. If lungs is the primary, then the kidney will compensate. Is everybody clear, folks? Now, how does the compensation work? Let's assume patient has metabolic alkalosis. If you have metabolic alkalosis, in my axis, I would say we are somewhere here, isn't it, folks? So we have to bring it down towards this way, which means towards acidosis, but we don't want to go all the way to acidosis, but we are trying here and then you stop here. Is that clear, folks? So for metabolic alkalosis, the compensation is hypoventilation. So your lungs will breathe less, so they could retain more carbon dioxide. So you're balancing by adding acidosis. Is that clear, folks? So for metabolic alkalosis, hypoventilation is the compensation. Has everybody understood that? Anybody has issue with it? If you don't do it, no. So now that's metabolic acidosis, that's the compensation. If you have metabolic acidosis, then the hyperventilation will be the compensation because the lungs will breathe faster to get rid of it so it can go back, okay? So that's how we compensate. Is everybody clear, folks? Now, if I tell you your problem is in the lungs, then your kidney will compensate. So let's say patient has respiratory acidosis. the kidney will compensate by reabsorbing more bicarbonate. So we're going to say it's retaining bicarbonate. So metabolic alkalosis is the compensation. It's opposite, it's the same direction. Is that clear, folks? And then if you have respiratory alkalosis, your kidney will lose more alkaline to become metabolic alkalosis, so they could compensate. Is everybody clear, folks? That is the compensation. Now, if you see the book, it has it nicely. Forget about these things, but look at the compensation. For metabolic acidosis, respiratory hyperventilation is the compensation. Does that make sense? So technically speaking, just for learning, you could actually say for metabolic acidosis, respiratory alkalosis is the compensation, just to understand that. Is that clear for you? So that's where we are going. If you have metabolic acidosis, metabolic alkalosis, then you will have hypoventilation as a compensation because we are trying to bring in more acidic. So everybody agree with that? Then when you have a problem with respiratory acidosis, your kidney will reabsorb more bicarbonate. You see that? They're just doing opposite to what your pH is. And when you have respiratory alkalosis, it will be excreting bicarbonate. So it's a compensation. It's simple. The last thing to pay attention, when you have metabolic problem, the problem is in the kidney. Your lungs can compensate faster because all they have is breathe. Does that make sense? All they have is breathe. Okay, so they compensate really fast. But when the problem is in the lungs, kidney takes forever to compensate. It takes a longer time. It's delayed. Okay. So respiratory compensation is faster than metabolic compensation. Everybody clear, folks? So to give an example, let's say a patient comes with metabolic acidosis. The hyperventilation probably 15 to 20 minutes, they will compensate quickly. But when it comes to kidney, it will take hours to compensate. Clear, folks? So that's your primary acid-base compensation. Any question for me? That's your 101 course, okay, basic. Now we're going to go on to the next step. When that patient has metabolic acidosis, we never say it's metabolic acidosis. You have to say whether it's a normal and 9-9 gap metabolic acidosis, normal and 9-9 gap, or increase and 9-9 gap metabolic acidosis. You cannot just say, if you say there's another notification, you're attending. If you say you're attending, you're going to get it back. Okay. Because they want you to talk whether it's a normal 9-9 gap or increase 9-9 gap metabolic acidosis. That's only applicable to metabolic acidosis. So we don't have to do that for respiratory acidosis, nothing else. Just for metabolic acidosis. So every time you make a decision, patient has metabolic acidosis, always find out 9-9 gap. So it's very clear, folks. Now, what is this 9-9 gap? Everybody's going to be sodium minus this. That's an equation, right? So to calculate 9-9 gap, you use sodium minus bicarb plus chloride. That's the equation, isn't it, folks? That's an equation. That's not a definition. The 9-9 gap means the difference between positive charge and negative charge in the body. That's a definition. Okay. That's a definition for 9-9 gap. The difference between positively charged and negatively charged. A good example for positively charged is sodium. And a good example for negatively charged bicarb and chloride. Now, is that the only positively charged ion we have in the body? No. There are so many positive, there are so many negatives. So why did you just pick these three? Because sodium is a high number. These two come closer to it. So it's a man-made equation. The scientist came up with this equation. That tells you the equation itself is not precise. That's clear, folks. If you want a precise equation, you have to add every single positive and every single negative. That's clear, folks. But this is a man-made equation, okay? So what that tells us, when you calculate a 9-9 gap, let's say we're going to make an example. This is 130, and this patient has 100, and this is 119. So what is the difference? 12, isn't it, folks? Right? So we call as as long as the number comes up to 12, these are normal and 9 gap. Up to 12 is normal. Up to 12 is normal. So when you do the 9 gap equation, if you get the number 1 to 12, it's considered normal and 9 gap metabolic acidosis. Is that clear, folks? If you get that number more than 12, let's say for example you are getting 14 instead of 12, that will become increase and 9 gap. Is everybody clear, folks? Up to 12 is normal. More than 12 is considered increase and 9 gap. Now, anybody wonder why up to 12 we call it normal? If you want, I will explain. If you don't, then I don't have to. Okay, so you guys wonder why up to 12 is normal, right? So remember, folks, how did we come up with this number to say that up to 12 is normal? Because what does this 12 mean? There's 12 negatively charged ions in the body. Okay, folks, there's a difference in here. So the minute you see 12, those are 12 negatively charged ions in your blood. So why do we call it normal? We have albumin. The standard units of albumin is about 4 deciliters something. So the number is 4 approximately, right? Each albumin carries 3 negatively charged ions. Each unit of albumin carries 3 negatively charged ions. So if I have 1, 3, I have 4 units. 3 times 4, how much? 12, isn't it, folks? So that 12 is normal because they are attached to your albumin. Albumin is part of your blood. Is that clear, folks? So whenever I do the anion gap equation, and if I get the number 12, I know that 12 negatively charged belongs to albumin, which is considered normal. Is everybody clear, folks? Okay, up to 12 is normal. Now again, remember, some of you might think that equation doesn't make sense. It doesn't, because it's a man-made. Okay, so that's why we want to stick to that number here, folks. Is everybody clear? So if you do a math, you get number 12, you're going to tell the patient has normal and 9 gap metabolic acidosis. Why it's normal? Those are belong to your albumin. Until we die, you're going to have albumin in the blood. You cannot change it. Is everybody clear, folks? Let's say I'm doing an anion gap. I get a number of 22. Total number is 22. What do you call this? Increase anion gap metabolic acidosis, isn't it? Why did I say increase? Because it's more than 12, isn't it? Are you guys following me? This is more than 12. How much do you have more than 12? I will do a math. From this 12 to 22, I will remove the 12 that belongs to albumin. Is everybody clear, folks? If I remove that 12, how much balance I have? 10, isn't it, folks? That 10 means there is a disease happening in your body. They are producing more negatively charged iron. That's why that 10 is there. I repeat again. If I get the number 12, I'm not going to do anything further. I would say 12 is considered normal and 9 gap, and I'm going to move on. Is everybody clear, folks? But if I get more than 12, I already know it's an increase in 9 gap. You don't have to do the math. You already know it's an increase in 9 gap. But I just want to know how much. Does that make sense, folks? So when I get a patient, so let's make up this number. Let's make up a scenario for this number. I have a 15-year-old kid. 15-year-old kid comes with abdominal pain, breathing fast, sweating, the breath smells of something. What's the diagnosis? What do you do for diagnosis? Type it. You should be able to diagnosis. 15-year-old abdominal pain, breathing fast, sweating, and breath smells of something. That is diabetes ketoacidosis. Okay, DDA. I didn't want to say ketones and give the answer. That's why I said something. Okay. So that's diabetes ketoacidosis. When I did the anion gap or the equation for diabetes negative resources. This is the number I get for that kid. This is the number I get. Everybody clear, folks? So when I see diabetic resources increase anion gap metabolic acidosis, that's what we learn on endocrine. Diabetic ketoacidosis patients that increase anion gap. How many people are lost so far? No, good. Now, when I did the math, 22, of course, I know more than 12 is considered increase. That's why I said increase anion gap. Don't you know how much exactly they have? For that, I need to subtract the 12 that belongs to your normal anion gap attached to the albumin, isn't it, folks? Then I get a number of 10. What is this then? These are the ketones in the blood that gives you the number because ketones are negatively charged. Is that clear, folks? Ketones are negatively charged. So when I say I have a patient with increased metabolic acidosis, there is a disease that their body is producing more negatively charged molecules. Is that clear, folks? Now, if you go to this equation, right, they change the name, but these use modifiers, right? Modifiers my reference, I speak to that. So if you see all these diseases, where there are diabetic ketoacidosis, ketones, all these produce negatively charged iron in the body. So because all these diseases produce negatively charged iron, when you do that anion gap, there will be always increase. Is that clear, folks?
When you come back that the 20% of the question that you just said is given by the, I mean, it's there in the question.
Yeah, it's a one question. They are already telling this number, or I could give sodium number and each individual you have to do the math.
Okay.
So you have 22. The minute I say 22, I know it's increase, and I'm just telling you how much exactly they increase. I will need 12 that belongs to albumin, because remember, this all belongs to albumin. You can't consider as pathology. Everybody clear, folks? Then 10. Once I treat this kid, all this 10 will go away. Is everybody clear, folks? Because my job of treating for ketoacidosis is to take care of the ketones. Are we clear, folks? So any disease that produces negatively charged iron in the body will cause increase in metabolic acidosis. Is everybody clear, folks? There are diseases they produce no anion gap. That means none of these diseases are producing negatively charged iron. Is everybody clear, folks? They are not producing negatively charged iron. That's the story about anion gap. Are we clear here, folks? Let's do a math. I'm going to give you guys a math. How about you guys tell me here? I'm going to make it hard. All right. Tell me what's happening. Chloride 85 by cal 22. What is the problem here? Is it normal anion gap or increased anion gap? So my math will be 140 minus these two, right? So 140 minus 102. That should be 38. Is that clear, folks? Is it normal anion gap or increased? As long as I remember, 38 is higher than 12. Right? So that is increased. How much is increased? I want to remove the 12 that belongs to albumin. That should give you 26. Did we get that right? So that means this kid has a disease happening in the body that is producing 26 negatively charged iron. We need to find out what it is and treat. Is everybody clear, folks? That's the story for anion gap. Any questions so far? No anion gaps. Okay. So we understood the anion gap. Now let's go to the last part, folks. So there is an easy way. When you look at the question, within 3 to 4 seconds, you could tell what's happening in this patient, folks. Okay. Now to learn this, you need to understand everything what we have done in acid base. Are we clear with this so far? All right. So let's go here. So I'm going to write pH and CO2. CO2 bicarbonate. You guys know the normal pH. Normal CO2 is 40 and the bicarbonate is 22 to 26. That's a normal number, okay? Start copying this. Copy these two numbers. This is a method I'm teaching. It's easy to identify. If you think you have your own method, you could stick to it. I don't want you guys to confuse, but see if you like this better than your method. Now, when I see this number, first one, I'm going to say patient A, patient B. When I look at these numbers, folks, you see, every time I see ABG report, I scan pH and CO2. That's it. When I look at this pH, is this an increased pH or decreased pH? Increase. So I'm going to put an arrow here. In the beginning, I will write the arrow, but eventually you do it in your mind. Okay. Increased pH. CO2 is 50. Normal is 40. So that's more than normal. Is that clear, folks? Okay. Let's do the same arrow for the other one. Decreased pH, increased CO2. You guys get this here? Anytime the arrow goes in the same direction, it doesn't matter increase or decrease, but it has to be both same direction. We call that metabolic problem. First, we find out respiratory or metabolic. That's metabolic problem. After you find that metabolic problem, pay attention to the pH. Is this an alkaline pH or acidic pH? That's an alkaline pH. So this patient has metabolic alkalosis. It takes 2 seconds to do this arrow in your brain, folks, okay? Here, the arrow is opposite to each other, isn't it? Whenever the arrow is opposite to each other, there is a respiratory problem. When the arrow is opposite to each other, respiratory, then I look at the pH. That's respiratory acidosis. That's all it is. When the arrow goes in the same direction or the arrow is opposite. Is everybody clear, folks? Now, let's do 2 problems. So to make sure you guys understand that. How do you want to do with the arrow? Here, the arrow is up, down. Did we get that? So that should be respiratory alkalosis. Did we get that? Because arrow is opposite. So we're going to say respi alkalosis. Here, the arrow is up. Ooh, what happened to the 39? Still less than 40. So arrow is down. Still respiratory alkalosis. Is that clear, folks? I just put that number. You need to stick to 40. That's all it is, folks. Okay. So that's a respiratory alkalosis again. Okay. That's your first step. By looking at this method, you could only diagnose what type of acid-base problem the patient has. This doesn't tell us if you are compensated or not. Is that clear, folks? So we need to get this first. Did everybody understand this method? All right. Now, if I ask you, this is A, right? Patient A. Patient has metabolic alkalosis. In order for you to answer if this patient is compensated or not, do you need bicarbonate or not? How many people think you need bicarbonate? So you think you could answer without bicarbonate? All of you guys. Wow, you guys are smart. Now, so since you guys said you could answer without it, type it up. Is it compensated, yes or no? Because you guys said you could answer without the bicarb. Livia's like, I should have asked bicarbonate. All right. All right. Yes or no? That's all you wanted to type. Yes mean compensated, no mean no compensated. Folks, you guys said you could answer without the number. Why is it taking this long? Okay, I will help you. You actually don't need bicarbonate. You don't need bicarbonate. Why? Who responds for metabolic alkalosis? Is it your lungs? What does lungs do for metabolic alkalosis? You tell me. Lungs should retain more carbon dioxide, isn't it? The normal is 40. They have 50. That means they retain extra 10. That means this is compensated. Okay, let me repeat again. Patient has metabolic alkalosis. For metabolic alkalosis, compensation is respiratory acidosis. Is that clear, folks? Respiratory acidosis means the normal 40, so it should be more than 40. Is that clear, folks? Here I have 50. That means it is compensated. It has more than 40, which means extra 10 molecules of carbon dioxide. So it's compensated. It's going slowly, but it's okay. Get it slowly. See, for metabolic alkalosis, you do not need bicarbonate to see if it is compensated or not, because the compensation happens in the lungs, which is already given in CO2. Is that clear, folks? Right? You guys get it? Okay, let's do one more problem. See if we can see if it is compensated or not. What's the problem? Equation. They both goes in the same direction, isn't it, folks? So that's metabolic acidosis. Did we get that first? Now, if you have metabolic acidosis, please tell me what's the compensation? Hyperventilation, right? If it is hyperventilation, mean I should lose all my carbon dioxide, isn't it, folks? That means the number should be less than 30. Sorry, number should be less than 40, right? But I only lost one. One is not enough. So it's still not compensated. But if I change this number to 30 or 25, you could say it's compensating. Okay, so let's make it easy now. So let's say this is 20. Can you say it's compensated? Yeah, they lost half of the carbon dioxide. Is that clear, folks? That's compensated. But if I change this 20 to 39, still not compensated because they only lost one molecule of carbon dioxide. That's not enough. So the question is, when do you say it's compensated? You want to look for like more than 5 to 8 molecules. It should be a big difference. Is that clear, folks? So in the exam, you won't get confused. They will give you enough number differentiation that you won't have a problem. Okay, so that is a compensated one. Is everybody clear, folks? Are you guys getting it? So when you know metabolic problem, the compensation is carbon dioxide. So you see if they have changed the numbers or not. Anybody has any problem before we go into the next one?
From a clinical and like for the actual exam, we should stick to carbon dioxide being between 36 to 44, right? Because it changes some of the answers in that case.
I know. So what I would recommend when you go into the exam or UWorld, what is the UWorld number for carbon dioxide?
I'm pretty sure it's like 35 or 36 to 44.
So in that case, stick to that. But you know, most of the textbook says 40, so that's why I use the number. But when you practice UWorld, stick to that number. So if the question says, the UWorld says 35 to 40, then you know between 35 to 40 is a normal. So for you to make a difference, it has to be either 45 and above or 35 and less. Does that make sense, folks? Because that's a normal number. But for easy to understand, let's stick to 40 now for us to get this first.
So for the lower part of the range, like if it's 35 to 45, we would want 5 less, like 30 and less. We wouldn't want like 32, 33.
No, yeah, you want to like a 5 or more difference in numbers. Does everybody understand? Anybody's lost? All good? Until you become pro, we are not closing today. We are learning this, even if it is another 2 hours. All right, next one. Respiratory acidosis. Can you guys answer and say if it is compensated or not? How many people say you want bicarbonate number? Now everybody's going to raise it. Okay. All right. So for respiratory acidosis, who compensate? Kidney compensates, isn't it, folks? Then you do need bicarbonate number. You see, you only have to look at the bicarb when the primary problem is respiratory, because for respiratory, kidney compensate. Did everybody get that, folks? Okay. Now I'm going to give you a number. So what's a normal bicarb? Between 22 to 26. Is everybody clear, folks? So I'm going to give you a number, 24. Is this compensated or not? This is a non-compensated because they are within the normal range. Is that clear, folks? They are within the normal range. So for respiratory acidosis, the number should be more than 26 because we want more alkaline molecules. Is that clear, folks? So if I change this 24 to 34, would you say it's compensated? So what do you expect for respiratory acidosis? I want more bicarbonate, right? The normal is 22 to 26. I have 34. You have literally more, almost 8 to 9 more than normal. So you could say this is compensated. Is everybody clear, folks? Let's try the same thing again. Here you have respiratory alkalosis. For respiratory alkalosis, I want you guys to tell me what is the compensation. Metabolic acidosis. Opposite, isn't it, folks? Metabolic acidosis means to say compensated, bicarb should be less than 22. Agree, folks? They should lose more bicarb. If I have between 22 to 26, I would say non-compensation. If I put 12, what would you say? It is compensating because we are losing, almost lost 10 of those. Is that clear, folks? I know it's a lot of info, but when you watch the video again right after class, it will make a proper sense. Look at this one, third one, respiratory alkalosis. Respiratory alkalosis, I want you guys to tell me, is this compensated or not? How many people say no? Why you guys say no? Because it's within normal range. Is that clear, folks? So for respiratory alkalosis, what should be the compensation? Gaining bicarb or losing bicarb? Losing bicarb, because bicarb is also alkalosis, so you don't want more alkalosis. So the number should be less than 22 to say it's compensating. Does that make sense, folks? So you only need bicarb only if the primary problem is respiratory. If the primary problem is metabolic, you don't even need to look at the bicarb. Is that clear, folks? This is the method I use it. Now, if you know a different method, stick to it. But if you think this makes it easier, you could practice this, okay? Now,
Can you explain the last one again?
so the last one here,
said
respiratory alkalosis, right? So when you see respiratory alkalosis, the compensation should be metabolic acidosis. In another word, your kidney should lose more bicarbonate. So to say it's compensated, it should be less than 22, or to say non-compensated, it should be between 22 to 26.
But it was 23, which was in the normal range.
Between 22 to 26 is considered normal. Yeah, it's considered within normal range. Anybody else? Ask me questions. Is it making it easy? Okay, so let's do one problem, okay? Tell me, what is this? I want you to tell me what's a problem, compensated or not. Go for it. Yes or no compensation, add that too. All right, so what's the thing here? This is down, this is high. That's metabolic or respiratory. It's a respiratory problem. So it's a respiratory acidosis. That's a primary problem. Did we get that? So tell me, for respiratory acidosis, what is the compensation do you expect? For kidney to retain bicarb or lose bicarb? For acidosis mean you want alkaline. So that means more bicarb. Is that clear, folks? Should be more than 26. I have 40. So that means it's very well compensated. Is that clear, folks? Very well compensated. If I erase this and put 25, you could say it's non-compensated. What's the problem? So the arrow down, that's a metabolic acidosis. Okay, that's a primary problem. Is it compensated or no? So metabolic acidosis, what's the compensation? Carrie, explain to me, what's the compensation?
You're gonna hyperventilate to decrease
You
carbon.
hyperventilate, that means you have to get rid of carbon dioxide. I have 20 instead of 40. That means I got rid of almost half of those. That means it is compensated. Is that clear, folks? Yes, Shubham, good? Where's the problem?
In the compensation only.
Okay, compensation. So let's do this one more time. So here, patient has metabolic acidosis, right? So when you see a metabolic acidosis, ask yourself, who compensates for metabolic acidosis? The lung should hyperventilate. Hyperventilate means you are breathing to get rid of the carbon dioxide. If normal carbon dioxide is 40 and now you have 20, that means you already removed 20 of those. That means it did the compensation. Is that clear, folks? If I were to put 39 here, you would say it didn't compensate yet because they just lost one molecule, it's nothing. Is that clear, folks? Okay, so let's say an opposite one. Okay, so try this. Let's work together. This is high. What is this one? This is also high, technically more than 40, right? So that's a metabolic alkalosis. Did we get that? So for metabolic alkalosis, what's the compensation? Hypoventilation of the lungs. That means the lungs should keep more carbon dioxide. Is that clear, folks? They only have one. That's not enough. We need more. It should be like 50. Is that clear, folks? So since it's only one, we call it non-compensated. Is everybody clear, folks? Still, any questions? So what I would recommend after eating, open that acid base right away. Watch that video 1 hour again. It's okay. It will make it much easier. If you understand the whole thing, go back to that last part of that and try it again, folks. Okay. There is a website. They have a metabolic problem. You could actually practice. It's called Acid Base Ninja or something. Anybody knows? If you know it, so it's, what is it called, Carrie?
It's like Ninja Nerd or something. I can look it up right now and I can post it in the chat.
Sure. So when you could practice 10, so they give you the number, you pick this. If you train 10, that's it. You will never miss that, folks. Okay. See, it takes like less than 5 seconds to tell what's happening on patient's body. Is that clear, folks? Try it and then watch the video again 1 more time, and then we will continue tomorrow. Any questions for me? All right.